and it's ultra fresh. If you get the endoscopic picture, can you give a glimpse of it? You'll be amazed to see like a live surgery going on. So this is ultra fresh, you can say. And the plans for the today. Our plan is, as we said, we'll start with the basics with the endonasal anatomy, dissection of paranasal sinuses. We have discussed a lot in the previous webinars and the live surgical sessions, but cadaver is something special where you can show more and more procedure in a less period of time. So we'll be showing all the approaches to each and every sinus, not only endoscopic, but whenever required, the open and the extended approaches as well, particularly the maxillary sinus. We'll discuss all extended approaches to the frontal sinus, as many as 5 types of draft or modified Lothrop's procedures, along with the open procedures like osteoplastic flap, cranialization of the frontal sinus, facialization, orbital transposition to go far laterally into the frontal and all that. After that, we'll move on to the various intranasal flaps, which are very important. When we think of endoscopy skull-based surgery, how this science has, lifted up. The science of endoscopy skull-based surgery is because of the availability of better reconstructions materials, and particularly the vascularized flap now. Ever since the Haddad and Basagestgi gifted this world that flap, which revolutionized the endoscopic sinus surgery, endoscopic skull-based surgery, there are so many flaps which have been introduced more and more now to reconstruct the skull base in different situations. So we'll be demonstrating all those flaps, intranasal as well as extranasal, which can be used for the reconstruction of the skull base in particular conditions. And after that, we will move to the surrounding areas like anatomy of the orbit in detail from inside the orbital approaches, as well as from the transcranial side, each and every fine structure in the orbit, neurovascular structures, particularly how they are coming inside the orbit from the optic canal and superior orbital fissure to go to their destination, to the various parts of the orbit, and the various highways to enter into the orbit. And after that, we'll go to the surrounding areas. We'll discuss about something about the nasolacrimal system, the Denker's approach, then the pterygopalatine fossa, infratemporal fossa, sphenoid, skull base, cavernous sinus, orbital apex, and then move on further to the other advanced skull base approaches. So let's see how much we can do today. Otherwise, we'll carry on further. And as you all know, we have already announced our webinars on Sundays and Thursday. So this Thursday again is always dedicated to the live surgical session. So this Thursday again, we are coming back with the advanced skull-based cases, live surgical demonstration from basic to advanced. And the next Sunday again with the cadaver and other advanced things. So thank you very much once again for joining us. And please feel free to ask questions, to send questions. Your questions are benefiting everyone. So it's I would say, obligation to us if you send questions so that we can discuss and everyone can be benefited. So, Dr. Prabhakaran, can we go ahead?
Yes, please, please.
Anything you want to comment or you want to suggest before we start, please?
I think it's fine. It's perfect.
Great.
Let's start. Yes.
Thank you. So, friends, this is the left side of the nasal cavity. I hope the picture is good. Or let me do a white balance. Just a minute to begin with. This laboratory at this prestigious institute, I introduced last time the chairman of this institute who has been kind enough in such academic activities. He is allowing us, and he is an amazing person with a open mind person who is inclined towards propagating the academic concepts. So I am really grateful to him, Mr. Sandeep Bakshi, for giving this opportunity again. So this is the left nasal cavity. Can you see this?
Yeah, very clearly.
Okay, so this side is the nasal septum. As I mentioned, we'll dissect this later with the flap, the Hadad flap later. On the right side, for the sinus surgeon, the key area of interest is in the lateral wall of the nose. This lateral wall anatomy is important to understand for every sinus surgeon. And to begin with, on this endoscopy, I'll just enumerate certain landmarks. So in the lateral wall, there are certain protuberances, certain depressions you can see all over. So this first structure in the lateral nasal wall, inferiorly, to begin with, is the inferior turbinate. You know, there are certain turbinates, prominences in the lateral wall. This is inferior turbinate, this is middle turbinate, and above that is the superior turbinate. You know, so these are the turbinates which are prominences or protuberances in the lateral wall, which leads to certain recesses underneath them. So this is the inferior turbinate. We'll discuss later in detail how important this is to us. So this is covered by a special tissue which is important in regulating the airflow and mediating certain reflexes. As we go behind this, we enter into a space, and that is known as choana. That is known as choana. This is a very important area. This space is choana, and as we go further, we see certain protuberance behind in the choana. And these are, on either side, the protuberance of the cartilage of the eustachian tube. Can you see this?
Yeah, very clearly.
Cartilage of the eustachian tube on either side, covering the eustachian tube orifice, which is leading laterally towards the middle ear. And there is another space behind this, you know, for the skull-based surgeon, it is very, very important. We'll see the importance later on, how important as a landmark it is. See, as I go behind, there is a cleft which is enclosed behind the eustachian tube far laterally. That is the fossa of Rosenmuller, which is a very important landmark for the skull-based surgeons to pointing towards the parapharyngeal carotid artery. Now, underneath this inferior turbinate is an important area. See, this is inferior meatus. This area is inferior meatus. It hardly contains any important structure except in the anterior part in the roof. See, I am coming there. Except in the anterior part of the roof, there is, see this? When I press on the medial angle of the orbit, see this? There is a lower opening of a duct which opens through a wall in the inferior meatus known as valve of Hassner's. So it opens in the anterior part of the inferior meatus in the roof, and it delivers the transport of the tears into the nose from the eye. And the malfunction of this system results into epiphora, which requires a formal procedure of cysto-rhinostomy. We'll show this entire anatomy of this system as well today. So now, coming from this inferior meatus above, this is a flat area in the medial wall of the maxilla, or the lateral wall of the nose, with relatively no neurovascular structures over here, known as atrium. And behind are the important areas the protuberance starts. So the first protuberance belongs to, again, to the nasolacrimal duct, which comes from above and open here in the inferior meatus, which we have seen just now. Behind this protuberance, this another protuberance. Can you see this mobile structure?
Yeah.
Yes.
That's the only mobile structure in the entire lateral nasal wall. That is known as uncinate process, and it has a huge bearing on the drainage flow or the outflow of the frontal sinus. We'll see. We have discussed in the radiology also. So it has two parts, the upper vertical part and the lower horizontal part going behind, if you follow this, to a variable distance. Sometime it ends here into the inferior turbinate only, and sometime it goes beyond up to the perpendicular plate of the palatine bone. Here is the palatine bone perpendicular plate behind the maxilla, and here is the horizontal plate of the palatine bone completing the hard palate. So it is horizontal plate, and this is the perpendicular plate, and the anatomy of the perpendicular plate is very important to understand for the sinus surgeons. Now, so this is uncinate process, which is generally considered to be the first step in sinus surgery. And as we all know, the well begun is half done. So a good uncinectomy is always a very important step for the sinus surgeon to accomplish a good sinus surgery. Now, moving behind the uncinate is a narrow cleft. This is a two-dimensional cleft where I am insinuating my ball probe. This is known as hiatus semilunaris inferioris. This is hiatus It is a semilunar shaped hiatus between this prominence and the next prominence behind, that is bulla ethmoidalis, that is the anterethmoidal cell. And this hiatus will see, once I remove the uncinate, how it leads laterally into a three-dimensional space that is known as infundibulum. So once I open this space, this step is known as infundibulotomy if I remove this uncinate to uncover the infundibulum, which is actually a three-dimensional space into which the maxillary sinus ostium opens. So this is bulla ethmoidalis. Now going behind the bulla is again a recess. See this? This is a retrobular recess. And how it is completed? This is the bulla behind this recess, and behind this a part of middle turbinate. So now, coming to the most important anatomy for the sinus surgeon, which remains all the way and which is required to be understood and respected and maintained, is the middle turbinate. So this middle turbinate is one of the most important structure you can see in the this part of the nose. So it has practically three parts in three different planes contributing to its stability. This is the most important structures which orients us throughout the sinus surgery, and stability of this step is very important. And here I welcome our colleague, neurosurgeon friend and the boss, Dr. Pankaj Gupta, who has joined us, and he has been part of our skull-based team for years when we started together. So welcome, boss. So this is the middle turbinate. It, as I mentioned, it has three parts. The anterior-most part lying in the sagittal plane, going up anteriorly, inserting onto this frontonasal process, and the posterior part going high up to insert onto the cribriform plate, a very important area at the junction of horizontal and lateral lamella. That's why this turbinate has to be gently handled as you go up towards the cribriform, so as not to give a damage to the cribriform and get a distant CSF leak. So this is one first important part lying in the sagittal plane. Then this turbinate, as you go behind, turns laterally in the coronal plane to insert onto the lamina papyracea. That is the second part of the turbinate lying in the coronal plane. And this space anterior to this and behind the bulla is the retrobular recess. Okay? And the third part, this sagittal part of the turbinate, continuing behind in the axial plane, lying, see, almost going to the roof of the nasopharynx, or sometime to the medial pterygoid plate, or the perpendicular plate of the palatine bone. And this goes like this in the axial plane, known as the third part of the turbinate. So all these parts together in different planes contribute to the stability of the turbinate. This is a very important structure anatomically as well as functionally. The reason is, all the cells which open anterior to the turbinate, they drain anterior to it. Like all sinuses, maxillary, the frontal to the frontal outflow tract here, and the anterethmoids, all staying anterior to the ground lamella, they drain anterior to it. And all cells like postethmoidal and sphenoid, which are behind the ground lamella, they drain behind it through the sphenoethmoidal recess. So this is important anatomically as well as functionally, as we deal with a surgery known as functional endoscopic sinus surgery. So we have to all the time respect anything which has a bearing on the function of the nose overall. Now, going behind, if I medialize this turbinate a little bit here to show you something, going behind, there is another turbinate. See this? There is another turbinate there. That is superior turbinate. The superior turbinate, and medial to the superior turbinate, this is the posterior part of the nasal septum, is an opening known as sphenoid sinus osti. Right in the midline. Medial to the superior turbinate, and as I told you, behind this ground lamella is the postethmoid sinus. So postethmoid sinus and the sphenoid sinus, they drain behind the ground lamella, and that region is known as sphenoethmoidal recess. This sphenoid sinus is considered, for the skull-based surgeon, is considered to be the center of universe. We all know the sphenoid bone, which is centered in the center part of the skull, is so complex a bone and has amazing relationship with the surrounding neurovascular structures. The science of skull-based surgery is standing based on this fact that this particular bone is pneumatized. And that gives us access, this gives us space to address the surrounding neurovascular structures directly without mobilizing the cerebral and other structures, and we can address them directly through this pneumatized space. And that is the basis of endoscopic skull-base surgery. So we'll move on to the skull-base later. So first, this is important for the junior colleagues, for the skull-base surgeon, for the team of skull-base surgeon, maybe neurosurgeon, to understand this endonasal anatomy. It's not important for ENT surgeons only. Those who wish to pursue their career in endoscopic skull-base surgery must be well versed with the anatomy of the paranasal sinuses, nose and paranasal sinuses, and the surroundings in detail. So this is about the initial, description of the endoscopic picture. Prabhakaran, anything you would like to comment or you do differently, please.
No, it's fine. It's very thorough. I like the way you correlated the soft tissue and the bony landmarks together. So that's a very nice overview before we start. Very nice, lovely.
Thank you. Samir, do we go ahead?
Yeah, please. The only thing is in a live surgery, if that inferior turbinate, sometimes we tend to outfracture it to get access posteriorly. So that helps in a little cramped up and narrow space.
Yes, that's a very important point elaborated. See this, what he's trying to say is sometimes this is over projecting, the bony projection, and what you can do simply by means of the back end of your curate, you can out fracture it to enlarge the space, the working space, and the area overall. And this, lot of studies have been, go to the literature. Now they say this works for at least 6 months. It may come back, but at least 6 months it works very well. And until then, if the surrounding inflammation goes down, it may not swell up and may not give the same problem again. So it's always a advantageous procedure if you do this, in case it is too hypertrophied or projecting medially and blocking the airway. So it is always good. Thank you, Samir, for pointing out. So now, coming to the sinus surgery part. Paramita, you can interrupt me anytime with question.
Yes, sir.
So now,
Sir, there are almost initially only at this stage, there are almost more than 3,000 people are watching you, and I'm getting messages from Pakistan, Afghanistan, Bangladesh, everywhere that out of which, sir, I would just like to point out this Dr. Riaz Afridi from Pakistan. He sent you a message that, sir, I'm COVID positive.
I know. I am praying God for last 4 days.
So he is watching. So our prayers and wishes are with him for the early recovery.
He's very good friend of all of us. He's very regular in.
And I'm praying God for his fast recovery. And he was treating COVID patient there and finally turned out to acquiring the infection. So pray God, everyone I'll request for his faster recovery.
Yes, sir.
So now coming to the, yes?
Dr. Satish, you just showed us the nasoclavian opening. What is the exact anatomy? Means where exactly into the lateral wall and that,
yes. So in the inferior meatal, this is important when sometime you do a inferior antrostomy, inferior meatal antrostomy, so as not to damage the orifice. So this lower end of the nasolacrimal duct actually opens. See, this is the anterior head of the middle turbinate.
Yeah.
Exactly 1 centimeter behind in the roof of the inferior meatus. See, in the roof.
Yeah.
In the roof, it opens from here 1 centimeter behind. So when you carry out the inferior meatal antrostomy, though nowadays it is almost obsolete to do inferior meatal antrostomy, so not to run towards the roof of the attachment of the middle turbinate, rather stay in the floor and little behind, so as to avoid injury to the nasolacrimal duct. And in these days, though it was earlier, considered for the drainage of the sinus, and after the Messer-Kliner and Stamberger revolutionized the concept of drainage pathway of the paranasal sinuses and sinus surgery came in, this procedure remained obsolete. But now, as more and more advanced lesions of the paramedian plane are being addressed through the endoscope, this again a lot of people use as another avenue for the instrumentation inside the maxillary sinus. But believe me, I will my message to them today, once they see the advanced procedures of the maxillary sinus, this no longer to be a beneficial procedure in the present context for any indication, this inferior mesial. And trust me, and for me, this is as good as obsolete for any purpose. Now, coming to the steps of the sinus surgery. As I mentioned, we'll start with the steps of the basics of the sinus surgery on both sides, and then we'll go to the advanced sinus surgery maneuvers, advanced maneuvers to the maxillary sinus, frontal sinus, and all sinuses for that matter, including open approaches. So for the basics, the first step, as I said, is unsinectomy. And as I said, the well begun is half done, so a good unsinectomy is important. You know, when this surgery burst in 70s, this unsinectomy would be done by using a sickle knife all along its attachment to the lateral nasal wall, all the way till the horizontal segment is going. This used to be a popular step to begin with. But the only concern to me, with this still a lot of people are doing, is I will show exactly once I remove this, how close this upper part of the uncinate to the lateral nasal wall. And sometimes when it is too close, and if you are not careful, you can get an accidental entry into the orbit. That too at the beginning of the procedures, which is counterproductive to the surgeon, to the attitude, to the temperament of the surgeon, and that is something to be avoided. Particularly if your junior colleague is doing, this is detrimental for him. May not be detrimental to the patient, this small complication, but this is something to be avoided. So what we propagate, this is like we discussed last time when Professor Sethi was there, we use the reverse biting. See this reverse biting? One word for the instrumentation for the junior colleagues. See this, I am in the left side of the nose. Take the advantage of this columella to park your endoscope, to take the help of the endoscope stability to park along the columella, and then introduce your instrument along the lateral nasal wall. Whenever you go in, your instrument along with telescope should go in. Whenever you come out, they should come out together. You want to show through the see through the external camera?
Yes, sir. Many are requesting you to.
Can you put a PIP? PIP jayega?
So also, Dr. Vinay Kule from Navi Mumbai wants to know the exact location for maxillary ostium and accessory ostium and the mucosal fold over it. So can you just show it once again?
Yeah, I will show if there are accessory ostium and show the importance of it.
Clinically, what is the occurrence of accessory ostium in your practice, in surgical practice?
It's variable. But yes, in 20 to 30% of the patient you can get. But the importance is once it is, you have to communicate to the natural ostium is always better. So what I'm trying to show, are you getting the external camera picture?
Yeah.
See my hands. My telescope is going along the columella, pressing on the columella, and my instrument is going along the lateral nasal wall. So instruments are converging. Keep your instrument ahead and navigate with your telescope behind. See this? As you go in, bring out together, introduce together. So you don't traumatize the surrounding mucosal areas, which is important for function preservation point of view. So what we are using here is a reverse biting. Engage your reverse biting in the hiatus semilunaris inferioris, like this. We advocate to turn it little down to stay away from the nasolacrimal system, as it is farther as you go down, and bite through it. Bite through it. Advance further anteriorly until you come across the hard bone. See this. The moment you come across the hard bone, you have to step, otherwise you may bite through the nasolacrimal system. See this, what I have opened. Yes. This is the three-dimensional infundibulum, can you see? And into which this is the ostium of the maxillary sinus. Can you see laterally?
Yes.
This far laterally is the ostium. So whatever defects you may find in the lateral nasal wall looking like ostium are never natural ostiums. Okay? What are those? Like Paramita mentioned just now, those are accessory ostium. If you find some opening in this region, maybe anterior or posterior to uncinate, looking like ostium, they are never natural ostium. They are always accessory ostium or fontanelle, where the bone is deficient and only 2 layers of mucosa on the other side, forming the walls of the fontanel. So those are punched out defects. They are never seen through 0 degree. And what I can do now, I can debride this redundant mucosa and this portion of the uncinate to open it further. So this is a sort of middle meatal enterostomy. See, the same thing is done by various people by various means. You can carry out. The important thing to carry out is not to peel off the mucosa to bare the area. At the same time, you can evert a little bit of mucosa and communicate if any accessory ostium there to the natural ostium. These are the important things to carry out in carrying out this middle meatal enterostomy. Anything differently you do, Prabha? It looks like you want to comment something.
No, it's nice. I like the way you explain the whole thing. What I usually do, technique is a retrograde uncinectomy. You come from the back to the front. I usually do antegrade, like what was traditionally taught, but I don't use a sickle knife. I use a Frears elevator. If you
okay.
You see it swing, you will know exactly the location of the lateral attachment of the uncinate process.
Yes.
If you put a Frears elevator into that location, and you only remove the uncinate and you go downwards, you take away the tail. The most important part of uncinectomy is to remove the tail, which Satish has showed beautifully. But not often, if you do a retrograde with a backbiter, will the tail go away. If you do not remove the tail of the uncinate process, the maxillary ostia is never fully open.
Yes.
So that is a different way of doing things, but the aim is the same. But the most important thing, I think, as what Satish has showed beautifully, is we need to preserve the mucosa all around the maxillary ostia. There's no point making a large opening if the mucosa is damaged and the mucociliary clearance is gone. One of the commonest mistakes that people do is they make a very large opening, but in the process of doing so, the mucociliary clearance is damaged because all the mucosa circumferentially along the maxillary sinus is damaged as well.
Yes, that's a very important point you have highlighted. And that is something, a message to the colleagues, everyone, that preserve the mucosa. That is most important.
It's not the size that matters. The size doesn't matter. For function.
Function matters. That is the take-home message. It is the size which doesn't matter that much as compared to the function preservation by means of preserving the mucosa. That is most important. Now, coming to the point you have made about the size.
Satish, two more points.
Yes, please.
That when you go in with your, whether it is your backbiter or whether it is the microdebrider blade, make sure that it goes in closed, because if you're opening the instrument and going in, you're creating too much of trauma. And the same holds good for the microdebrider blade. And not to create a both anterior and posterior raw area in the maxillary sinus opening when you're trying to widen, because that's where you will finally then land up with a circumferential reduction in the size. So either we go posterior, which most of the time we do, or sometimes a little anterior.
Yeah, and that will affect the mucociliary clearance as well. So that's an important point in introduction of the instrument, like Samir has mentioned. See, if we traumatize the opposing mucosas in the nasal cavity, what will happen ultimately, leading to too much of crusting and synechias. And you know, in the sinus surgery we discussed in the first webinar, the concept, the goal of sinus surgery nowadays more and more is to introduce post-operatively steroid solution. And if you get a lot of synechia, that defeats the entire purpose. So, as a small step, what Samir has mentioned to prevent synechia formation is the introduction and bringing out the instrument how you do, it matters. And that is something important as an important point in our practice.
So which degree endoscope are you using right now?
Right now, wide angle 0 degree. But I tell you, for this question, I use only 2 telescopes, 0 and 70. And that for that matter, how I'm used to, I find 70 degree to be more versatile for the reasons I'll tell you. And my message is, we must get used to the angle telescope to carry out some, the visualization of certain different difficult areas, making them under vision to carry out the work without giving complication. So now, this size, like Dr. Prabhakaran mentioned, doesn't matter much. Yes, agree to him. And this is an adequate size for a regular sinus surgery. But, and as we all know now, the indications are expanding and we are doing for much more indications than only the inflammatory diseases of the paranasal sinuses. Why we are gathered here from an understanding, for understanding the anatomy of nose to the skull base. You know why? In 70s, when this science of endoscopic sinus surgery burst, because of this phenomenal work by Messer Klinger and Stamberger, it revolutionized the concept of endoscopic sinus surgery. It revolutionized the concept of treating the chronic rhinosinusitis. But as it came into the practice, the applications kept on expanding. Now, in the present context, this is not only the preferred treatment for the chronic inflammatory disease of the paranasal sinuses, but other non-inflammatory lesions of the paranasal sinuses, like even tumors of the paranasal sinuses, not only benign, even malignant tumors. Again, not only paranasal sinuses, but beyond the surrounding areas, like I mentioned, we'll show the anatomy, like pterygopalatine fossa, infratemporal fossa, parapharyngeal, all the lesions, de novo lesions of the area, or the lesions extending to those areas, the preferred technique approach is endoscopic, with certain advantages we'll enumerate. Lesions of the orbit, particularly the medial lesions, the best approach is endoscopy in the present context with minimum morbidity. And not only that, the skull base. Not only lesions of the skull base, benign or malignant, whatever, but it has become a preferred approach for many of the intracranial lesions now. With more and more advancement in the surgical technique, in the instrumentation, in the equipment, image-guided surgery, radiology, and this, I can attribute this advancement to so many things which had made possible now this endoscopic approach to be the preferred approach for addressing so many things. So we need to understand the three-dimensional anatomy of the entire region. And that's why I believe this science of endoscopic surgery is the fastest growing subspecialty in the entire medical science now, as more and more indications and applications are expanding. So nowadays, for different indications, we need to enlarge and give a mega middle meatal antrostomy. So like I have extensive fungus which requires a long-term surveillance. I need to enlarge this, not only for surveillance, but for introduction of my steroid solution or other solutions in the post-op period. So we create a mega middle meatal antrostomy. How can you enlarge this? See what is there in the posterior wall, medially here. This is perpendicular plate of the palatine bone. So I can enlarge it at the expense of the perpendicular plate of the palatine bone, posteriorly till the posterior wall. See this? Acha de, through cut de. Acha. Give me a good through cut. दूसरा दे. नहीं, टेढ़ा. ये दे. So I can enlarge this medial wall posteriorly and flush this till the posterior wall to give a mega middle meatal antrostomy, you know. So that is horizontally a mega middle meatal antrostomy. If I want further, with more gravitational drainage, I can flush it till the floor of the nose.
Yeah.
Or if you want further surveillance, gravitational drainage, like many a time we do for tumors, we can do a complete, medial maxillectomy, so that the entire maxillary sinus can be marsupialized to the floor of the nose or nasal cavity. So the variety of middle meatal antrostomies can be accomplished according to the need for the indications you are doing for, and that's how we should be able to do all this. So you can enlarge according to the need. Here, at this point, we must be careful about certain things. Though I will come later in detail about the anatomy in this region, but here I need to point out certain issues. See this? The posterior part of this bone. This is the palatine bone. Can you see this?
Yeah.
This is the palatine bone, and see posteriorly the attachment of the middle turbinate.
Yeah.
See this? And see something coming out from behind the posterior wall of the maxilla. And that is the something, if you follow. See, a lot of nerve fibers which I have severed. Can you see these nerve fibers?
Very clearly.
These are the posterior nasal nerve fibers coming through this pterygoid bone into this flap. See this? And this crest of the bone, see this crest of the bone? If I punch out this bone,
Yes, sir.
immediately behind that is the sphenopalatine artery. So we'll come to that anatomy a lot later, but see how this is in close proximity to where we are
sir.
working. Yes.
Satish sir, can you show us the blocks then? The blocks that we give?
What?
Blocks? You're not giving now.
The block? Do you
Local blocks?
The sphenopalatine local blocks.
Local blocks, I told you during live surgery, in any nasal or the skull-based procedures, we are not infiltrating at all. We are solely relying on the pre-operative preparation, intraoperative preparation, including topical saline adrenaline, and the anesthesia help from the anesthetist by means of reducing the cardiac output, by means of reducing the heart rate. All those things together, along with doing all these procedures in the reverse Trendelenburg position, we're able to get a good optimized field rather than infiltrating and giving unnecessarily an opportunity for the adrenaline to spread in the systemic circulation and give complications. So we don't infiltrate for that matter.
Okay, sir.
Yes, for the reason you asked, few years back, Professor P.J. Wormwold publicized and propagated the concept of infiltration in the, the Greater Palatine Canal. And he published a paper sounding a huge benefit when you infiltrate the Greater Palatine Canal in the surgical field, overall surgical field. So, I can show that you have to infiltrate through the, oral cavity anterior to the 1 centimeter anterior to the palate and go in the Greater Palatine Canal and inject so that it gives a spasm in the vessel overall, that is sphenopalatine artery. So that has an impact. You can use it in tumors, but now with the overall preparation, like I said, you don't feel like doing it. And a lot of people are not doing it for that matter. Prepakaran, are you using any time?
No, I don't infiltrate either. I do the same way, just the packs. Because I usually pack the nose before I scrub. So by the time I scrub and come back and get everything ready, it's almost 10 to 15 minutes. That gives more than adequate chance for the vasoconstriction. So I don't infiltrate either.
Oh, great. So we belong to the same philosophy, not infiltrating. And unnecessarily, I believe it's a good way of preventing unnecessarily complications of the infiltration.
So Satish is very good point for PG. They maybe query for them. Said what is the technique that master technique from anterior to posterior or Bormal technique from posterior to anterior? What exactly it is from where we move and where we come out from the nose?
Yeah, we'll discuss all that. For that matter, see, this science is evolving. I'm removing the upper part of the uncinate, with
Sir,
a red 40 debrider.
So here you tell us the upper limit till where you will have to remove the uncinate.
Yeah, that's what I'm coming to the very important part. Now see what I'm trying to say here, like I mentioned to Professor Prepagaran, why we use this reverse biting for the uncinate and not the sickle. See this, as I remove the upper part of the uncinate, how close this is to the medial orbital wall. This is medial orbital wall where this bulla ethmoidalis is attached to. And many a times we have seen this is even more closer to this uncinate, and the moment you stab your sickle knife, you are in the orbit. So you have to be very good at the radiology if it is so close to, and avoid that. And Professor Prepagaran is so experienced. He can blindedly do all this. But for the junior colleagues, always go to the radiology, see if it is very close to, then you have to stay more careful. That is the bottom line. And see, this is the medial wall of the orbit. At the first step of the uncinectomy, we reach the lateral wall of our limit of the entire paranasal sinus dissection. Got my point? So that's the lateral wall of our corridor. That too at the beginning of the Surgery at the first step of uncinectomy when you remove the upper part of the uncinect. Okay? Now, coming to the Paramita's question, that's very relevant. How to go up and how far to go up to remove the upper part of the uncinect. I mentioned in the beginning, this upper, I have changed to 70 degree for everyone.
Yes, sir. Yes, sir.
Is the picture good?
No,
Yes,
not
it is.
very good. Clean the lens, I think, or
Okay.
endoscope.
Okay. Okay. So now, see now with the 70 degree, let us first orient you.
Yeah,
This is the middle meatal antrostomy you saw.
yeah.
And if I go inside and rotate, you see the interior of the maxillary sinus. And what I can show you, what is it now? See the prominence in the roof. Can you see that neurovascular bundle?
Yeah,
Yes,
yeah.
sir.
Yes.
That is the infraorbital neurovascular bundle in the roof. And we'll dissect it when I come to the maxillary sinus later, expanded approaches. I will show how important a landmark it is. The infraorbital neurovascular bundle, how important a landmark it is. And we'll show a technique nowadays. Even you can go beyond that endoscopically by means of transposing this entire neurovascular bundle. See that? That is the interior, and if you rotate, if I rotate further, you can see even the anterior wall. You can see now. So this is the interior of the maxillary sinus, and this is 70 degree. I told you this is so versatile, I can make it 0 degree. Which degree telescope is this now?
70.
70.
Looks like 0 degree.
Looks like 0.
See?
Yes,
The
sir.
same picture, Prepa.
That's
The same picture like you see with the 0 degree. The reason is I made it more vertical. And I can work it like 0 degree. Now when I make it horizontal, I can work it like any degree I want to. This is 70 degree now. If I want to work further in the interior part of the roof, I will make it more horizontal and make it even up to 120 degrees. See this?
Yes.
So this 70 degrees, such a versatile telescope. With one telescope, you can do the entire surgery without changing the scope again and again. And for that matter, you need to get used to. And here, the most important thing why I've changed to the 70 is to show something. And this is considered to be one of the most challenging areas for the sinus surgeon to understand the frontal sinus anatomy and dissection and surgery onto the frontal sinus. And for that reason, we need to understand certain anatomy. Number one, see why we are frightened, so frightened with the frontal sinus work. We are frightened because of certain possibility of complications. Frontal sinus is so close to skull base, we are always scared of giving a CSF leak. We are always scared of injuring the orbit as it is in close proximity there, in close vicinity, and injuring the anterethmoidal artery sometimes. So, all these fears make the surgeon frightened. If you use a 70 degree, believe me, I'll tell you the landmark, you can easily access the frontal sinus without any problem. The only thing is visualization, landmarks. So, the landmarks for the frontal sinus, what I believe, this is the medial orbital wall we have seen.
Yeah.
Now, with 70 degree telescope, keeping in view all the time, if I keep my medial wall all the time in view with the 70 degree, wherever up I go, and don't cross this limit, I will never damage the orbit. As simple as that. This is one. Secondly, we all know this middle turbinate goes up. See this, how it goes up to insert onto the cribriform plate. As long as we stay lateral to the middle turbinate, there is no fear of damaging the skull base. So again, keeping with the 70 degree in view, see why this 70 degree is keeping both the medial and lateral limit in view. Lateral limit orbit, if I don't cross laterally, I will no fear of injuring the orbit. If I don't cross it medially, I have no fear of injuring the skull base. So that is fear number 2, you can avoid using the 70 degree as you go up. Third is, I'll show you some landmark which God has given us, and I believe that is the most important landmark. Give me. And that is your beak. This frontal beak is one thing which has made our life difficult. By means of making this frontal sinus access so difficult, as beak always comes in the way, and made the frontal sinus so high up, strategically located. So this beak now, if you follow, this frontal sinus drains from behind. All anteriorly it is flowed by the beak. So as long as you follow the beak behind, you follow the beak behind, and where the beak ends is your frontal sinus. So now, see now, this is your medial limit, this is your lateral limit, and this recess with a 70 degree, if I go inside, can you see the frontal?
Yeah, very clear.
See, so simple this is, such a favorable situation. Most favorable, like child's play now, if you have a 70 degree in hand. In any given difficult situation, because this area is not always so straightforward. There are so many cells which complicate your life, particularly in the presence of the disease. There are certain group of cells I mentioned in the first lecture, second webinar on the radiology, are the first group of cells which are lying anterior to this. See this cell lying anterior to the, this is my access to the frontal sinus. See now, how it is narrowed? By this cell. What is this? Agarnase. So there are certain cells which are lying anterior to the frontal drainage pathway, and for them the simplest is Agarnase. If there are more pneumatization of the frontal bone, this is frontal bone above. More pneumatization of the frontal bone above, which is described by the Kuhn's as a Kuhn's classification, type 1, 2, 3, showing the degree of difficulty which these frontal cells can pose to the surgeon. Type 1, one cell above it, you can go behind that cell and come out. Type 2 is one more cell above it, or tier of cells above it, you have to go all the way above them to get them out. So for any cells which are in the anterior wall, which are in the anterior wall of the frontal recess, the basic fundamental to the surgeries go behind them. See this? They like this Agarnase. I am going behind that and fracturing it out. Can you see this?
Yes, sir. Sir, when you're in this region and when you're using the 70 degree, I would request if they can also show the PIP of all your external maneuver that you're doing with the 70 degree scope. That will be very helpful for everyone.
My scope is parked close to the columella. Pressed to the columella. So my left hand is almost immobilized. You may find that my hands are so stable. It's not like my hands are like you only. It's not like hands are stable. I have stabilized them taking the help of columella where I parked my endoscope, and the right hand, through the right hand, I'm using my dissecting instrument like the microdebrider this time. See now,
yes,
I've removed this Agarnase and flushed with the lamina peperecia again. See this? And this has opened the frontal sinus pathway. Now, any cells lying anterior to the frontal recess are to be addressed like this. Go behind and fracture them out. The reason is the direction is away from the skull base. Now imagine there are cells on the posterior wall. Where in the posterior wall? Like, give me this thing. Let me show you. Had I been having, this was the cell here anterior to it. Had I been having cells over here on the posterior table, I would not afford to go behind it and fracture it out anteriorly. Otherwise, I would end up entering the skull base. So in those cells which are on the posterior wall of the frontal sinus outflow, they need to be opened from anteriorly and flush with the posterior wall rather than going behind them. And this discrimination, you have to plan. You cannot know unless you have a good understanding of the CT scan, which you can do yourself by means of a 3-dimensional CT scan on a DVD. And in that situation, you can get to know very easily that which cells are anterior, which cells are posterior, and you can literally get them out. So, by means of this, what I am trying to achieve, first of all, what I am showing is impossible if I am not using the 70 degrees, number one. The reason is the visualization. At every point of time, I am looking at my limits. See this? My medial limit all the way, this turbinate, and lateral limit all the way so that I don't cross my limits. I remember this was 2006 when our dear friend Ashish Bhumkar presented in the international workshop in Jaipur. His concept of, box, the frontal sinus outflow passes through a box, the fixed anatomy that is box of bones all around. We need to take just advantage of that anatomy. See, I have not changed the anatomy. Whatsoever the cellularity is here in between, your limits are same. Your lateral limit, the orbit is going to remain same. Your medial limit, turbinate is going to remain same. Beak, going to remain same. Even in the extreme revision patients, extreme revision or number of surgeries done earlier, these three landmarks are almost always prepared. Even if the middle turbinate chopped, you may find the upper part intact, and that may serve you as a good landmark to prevent skull base entry. Orbit is always preserved, and this frontonasal recess is the most reliable landmark in multiple revision surgeries, which is never touched even. So taking the advantage of these fixed landmark, we can make our entry into the frontal sinus simplified. Okay? Now, the cells behind are, for that matter, to enumerate, these are the cells anterior, which I mentioned, the Agarnagi and the Kuhn cells. Behind are the bular cell, suprabular cell, frontobular cell going into the frontal sinus, and so on. And supraorbital cell is a lateral cell pressing from lateral side and narrowing the drainage from lateral side. Similarly, a cell, here most anteriorly, is the intersinus septal cell, which narrows the drainage from medially. So all this cellularity we must sit with the CT scan at least for half an hour and run in three-dimensional plane to understand what area we are operating upon. We need to be well versed with the three-dimensional anatomy of that region so that we don't commit any mistakes, complication, to cross our limits and give complications to the patient. Prabhakaran, anything to add on? We need your comments.
Beautifully done. I think the only other thing that we need to preserve as much mucosa as possible, because if we leave bare bone exposed,
absolutely,
then we get fibrosis. But I agree with what you said. As long as you know where your enemies are. So in this case, your enemies are the orbit, the skull base, or the brain, and the anterior model artery. As long as you know where they are, you can remove everything in between them, as long as you preserve the mucosa. Very nicely done.
That's important. So that's, I would say, that is a take-home message from the master. Preserve mucosa. See, in the recent classification from the American Society of Rhinology, the most difficult of the frontal sinuses are those wherein the previous surgery has given fibrosis and neo-osteogenesis. And those are the most difficult to treat situations. And that is only and only because of leaving the raw areas, by extirpating mucosas and allowing the granulations to form a neo-osteogenesis and ultimately narrowing of that region. And that is most difficult to treat. So we should be very, very careful in working in the frontal recess, and like you can see here, preserve mucosa like Professor Prabhakaran said. This microdebrider is a mucosa preserving tool. It cuts sharp, it doesn't pull. We can use through biting, sharp instruments, microdebrider, all these help in preserving the mucosa rather than peeling them off. Now,
You will,
in a difficult scenario,
pardon?
in a difficult scenario, if we hug the frontal beak with an instrument and then slide the instrument just along that beak, the place where it will give way will be going into your frontal recess area. So do you think in difficult cases that will be an approach?
Absolutely. That's what I'm coming to show, that what Samir is saying. That is the bottom line of our philosophy. Out of these three landmarks, the beak is the most reliable one. The reason it makes the floor of the frontal sinus. And as you follow the floor behind, Follow the beak behind where it ends. It has to be frontal sinus. Whatsoever the cellularity is, it can never change. So in multiple revision, most difficult when you are disoriented, you are completely lost. Forget everything and just follow the beak. And that's what I'm going to show next. So that you will never miss the frontal sinus in place. That's a very important point, Samir.
Yes, sir. So will you also tell us the axillary flap approach to the frontal recess?
Yes, I can show that. And that is a concept propagated by a genius, none other than Professor P.J. Wormold. You know, we all know Professor Wormold.
Yes.
Is phenomenal, for that matter. What
you
he
have
has
shown this intact bulla technique. What is the indication of doing this intact bulla technique in surgical practice? Dr.
Yes.
Prakash Mukha is asking.
Yes. Convey my regards to sir. Prakash Mukha sir. His questions are always, is a genius. Sir, I am coming to it because I have not touched the third part, the anterethmoidal artery. See, my bulla is intact. And I'm still not worried about any other complication like anterethmoid so far. I'll tell you the reason, sir. I'm coming to it. I'll definitely address this. So now, what Samir was saying, this you follow the beak. You follow the beak where it ends has to be frontal. Believe me, in any given situation of the frontal sinus you are operating, that patient may be the most difficult anatomy might be having, may have been operated earlier several times, but what he has mentioned, Samir, exactly this is, I am trying to show what you have mentioned. This is my lateral wall, this is my medial limit, and this is my beak. Just follow the beak, staying between the lateral and the medial limits. Staying between. Follow the beak, and wherever the beak ends, it has to be frontal. Because this is not what we have devised. This is God's given anatomy, which we are taking the advantage of. That this beak forms the floor of the frontal sinus, and where it ends posteriorly, the frontal drains. So we are just taking the advantage of it, but it has a huge implication in simplifying our approach. Number two, Paramita, the axillary flap approach, right angle, as propagated by Professor Wormold, what I believe initially, probably 2 decades back, right angle, 2 decades back, when the 70 was not in use. So his concept was to remove the part of the axillary bone to facilitate entry into the frontal even with a 30 degree. See, he is so perfect in doing that still, that without giving any complication, which is other, right angle, ye dena. Ye wala. So, he is so perfect, he still does it without giving any complication. So what exactly does it? He raises a flap of this region like this. I raise a flap here. I am not raising, just to show you. Elevate it towards the turbinate, and then take away this bone of the axilla. So that hindrance to the frontal entry is gone, and you can enter into the frontal little easier than otherwise is. So that the fundamental is behind that approach is to facilitate your entry into the frontal much better, but still it cannot beat 70 degree. If you have 70 degree, you don't need to do all that. Okay. Now the second question is how big this opening should be. I have been asked several times this question, what size opening one should leave or give at the end of the frontal sinus? What size entry? So, to me, there is no fixed size. We cannot determine a particular patient's anatomy. Some patients have a huge pneumatized frontal sinus, and some have a small frontal sinus. Still, patients do well as long as their mucociliary clearance is good and the sinus outflow is maintained. So size doesn't matter. But once you are operating, our fundamental is, if you are operating on the frontal sinus, do a complete job. Complete job means flush the frontal sinus to the limits. So like, I flush this to the lateral limit. See this? No septa is overhanging. Overhanging septa may bridge the mucosa and can lead to stenosis. So our principle is follow Follow the limits. See my medial limit flush with the turbinate. Lateral limit flush with the lateral wall. Posterior limit flush with the skull base. And anterior limit to the beak. That is the final size one can give. There is no question of discussion regarding size in centimeters or so. No point. As long as you flush to the limits with, like Professor Pepagaran said, keeping the mucosa intact, it is good enough. Maybe it is 7 millimeter, maybe 2 centimeters, doesn't make any difference for that particular patient. Now, having done this wall I just said you, this is important that you can't go beyond the orbit is there. This you can't transgress, the skull base is there. Behind this is posterior table where the skull base is there behind. In the extended approaches to the sinuses, now you know, as I mentioned earlier, the applications have been expanding. And Professor Wolfgang Graf had described, he revolutionized the concept of frontal sinus surgery again, the endoscopic concepts, by introducing certain approaches known as Graf approaches, expanded approaches to the frontal sinus to address difficult areas of the frontal sinus, extensive lesions of the frontal sinus, and those he described for that matter, now the applications have expanded for other regions. Not only for the sinusitis.
How do I put my name in? This is showing as iPhone.
Not only for the sinusitis now, this approach is being more and more used for the other skull-based pathologies to deal with the CSF leaks. Some mic is on in between.
I think Dr. Milind Kirtane sir is joining us.
Welcome, sir.
Yeah,
Yes, sir.
my connectivity is very poor, so I hope it remains like this. So
No, sir, we can see you and we can hear you as well.
We can hear you, sir. Welcome.
okay, fine.
And I know sir is in Lonavala. So I understand the connectivity issue there. You are at the hill station, sir.
Emergency because of the,
And
I am not able to enjoy the hill station.
you know, we are so grateful to sir for his presence today. And he is always involved like anything. And today he was quite excited for this occasion of Remembrance Day for Stamberger. He said, I would definitely make it. He is at Lonavala presently at the hill station and still he made it. Thank you, sir. So what I was saying, for the expanded indications of the frontal sinus, what Graf had described, the only area which we can expand or where the entry of the frontal sinus can be enlarged is the anterior wall. See, there are no critical structures onto the anterior wall. An anterior wall, you can go right up to the external skin. There is no neurovascular structure to damage. So, this frontal sinus is above, this is floor. So the Graf had described variety of procedures to marsupialize the frontal sinus in the nasal cavity to prevent the future obstruction to the ventilation and drainage, and we'll discuss those in detail today. So that is when you expand the anterior wall, and this anterior wall is a thick bone. See, from here to here, it is almost a 1.5 centimeter thick bone. You can see this. This thick bone is obstructing our visualization of the interior of the frontal. If I remove this thick bone, the entire frontal will be marsupialized, and his technique of Graf, which he has classified into type 1, 2A, 2B, 3, we'll discuss in detail, and a lot of other modifications to the Graf procedures. And these Grafs are the endoscopic version of what Lothrop described more than 100 years ago. The same marsupialization of the frontal sinus, but from outside, which now we can do endoscopically. That's why we call it as an endoscopic modified Lothrop's procedure as a Graf 3, which Lothrop had described more than 100 years ago from outside, the same procedure. So we'll discuss that in detail. The only thing what I wanted to point out at this point of time articulating, the only anterior wall can be expanded safely. And that is how we expand our entry into the anterior wall. Now, I'm showing you one tool. I call it as an articulated punch. See this? If you really want to punch little bit of the beak to enlarge further entry here, not much, a little bit of the beak. See this? I can take away this mucosa. This is a punch. We call it as an articulated punch. See this? And see our entry has improved.
Yes,
Can you see this?
Yes, sir.
This is articulated punch which can help you sometime in improving your frontal sinus.
Can you show us? Can you show us this instrument?
Yes, this is 9 articulations. There are other available with even 16 articulations. You can see this. This is from Karl Storz, the articulated punch, and it's an amazing tool. Our frontal sinus tool are altogether different. They are long angle instruments, and there are more than 30 instruments we use at different processes of different sizes into the frontal sinus for required reason. Okay? Paramita, do we go ahead? Any questions?
Yes, sir. Yes, sir. Sir, can you show us the supraorbital cell? Can you tell us more about?
Yes, that's what I was coming to. In this patient, probably, fortunately, I mentioned, he has the most favorable anatomy. There is no much of cellularity behind to obstruct the frontal drainage pathway, and one of them is the suprabular cell. Even this bulla, see this bulla? This bulla is not extending to the skull base. This can be dangerous sometimes. Why I'm saying this? This bulla normally in over 95% of the situation go up to the skull base there. And in that situation, it covers the anterior ethmoidal artery on its own. Coming to the Prakash Mukha sir's question, that is very, very valid. Why we kept the bulla intact? See, our bulla is intact here. The reason is, we expect this bulla when reaching through the pre-op radiology, reaching to the skull base, we keep this intact so it automatically protects our anterior ethmoidal artery.
So, sir, can you show us the landmark now for the anterior ethmoidal artery?
Yeah, you can see the artery itself there now. It is uncovered. I told you, once this bulla is not reaching to the skull base, this can be dangerous sometime if you are not aware of it. And this artery, see this, it is not covered by any bulla or anything. Your instrumentation can damage it. So, the pre-op radiology is so important, you need to see whether bulla is reaching to the skull base or not. And in that situation, your intact bulla technique preserves your ethmoidal artery behind from damaging by the surgeon. And these concepts were very well propagated long back by our own Professor Sethi. We discussed in the last webinar, and Professor Sethi was there, this concept of intact bulla technique. So thank you, Prakash Mukha sir, for this interesting discussion. So this was about the, the bulla, which was very rudimentary in this case. See this, only a small one. It was not protecting right up to the skull base. It was not going up to cover the anterior ethmoidal artery. Now, another advantage of 70 degree. When we use 70 degree directing to the anterior, to the beak. See this? Our direction with the 70 degree and instrumentation are towards the beak. We are always away from the territory of the anterior ethmoidal artery. So we automatically are directed away from the anterior ethmoidal artery to damage it. So once you are using 70 degree, you need not to be so terrified with the anterior ethmoidal artery as long as you are directed anteriorly, as long as your bulla is intact. In this patient, the bulla is so rudimentary, you can see. Now I am removing this. So rudimentary.
Sir, Dr. Sanjeev Golhar from Nagpur is asking, can we drill beak, the frontal beak?
Yes.
And if yes, then which situations can
Yes, Dr. Sanjay, I will totally show. We are here today for all those extended procedures of the frontal sinus. I will show you all 5 types of the draft procedures today. Not 5, 8 types of the draft procedure. What we have done already, according to the draft, when you go to the level of the frontal sinus ostium, it is a draft 1. So you have already done a draft 1. I will show what is 2A, 2B and 3. What is subtotal Lothrops, what is hemilothrop, what is mini Lothrops, what is central Lothrops, and they have their own indications now. We have huge number of cases doing all these variations for particular indications, which I am going to share with you.
Dr. Sandeep from Bareilly, I want to know regarding frontal osteotomy, types of frontal osteotomy.
Yes, that's what I'm saying, boss. Sandeep, boss, I will show all the varieties of frontal sinus, these procedures, which can be very, very helpful in our clinical practice, and that will shatter everyone's fear regarding the frontal sinus. See, when we discuss sinus surgery at any platform, most of the audience have fear or the, some sort of inhibition regarding the frontal sinus work. And it is only because of, I tell you, the number one reason is the inability to use 70-degree widely. And number two, the fear of complication. And to shatter those fear, I am here today to apprise you of all those fine details by means of which you can carry out this work very, very safely. So this is about the frontal sinus in this situation in a regular one when you do a sinus surgery. Now I'll go back to 0 degree.
Dr. Kusum Patidar is asking, you have not used debrider till now. So in practice also, can we go up to...
I've been using debrider, madam. All the way I'm using debrider.
In frontal sinus, how much we can go with the debrider? Up to what level?
I have already mentioned, madam, in frontal sinus or anywhere. See how I am able to preserve this all mucosa everywhere. Can you see this?
Yeah.
All credit goes to debrider. The debrider is the tool which cuts the mucosa sharp and you can really preserve it so well. Had I been using my forceps or anything, I would keep pulling the mucosa and would have left a lot of raw areas. If you leave a lot of raw areas, I always mention, bare areas for the mucosalization later, that bare area may acquire infection, a lot of crusting, granulation, fibrosis, scarring, and that ends up with total mess, not fess. So believe me, it is the mucosal preservation which actually holds the concept of functional surgery. And for that, this debrider is key tool state. Now,
she's also mentioning that this presentation is very good for the PG student who have not could not read because of the COVID duties. So I think they can go through with this demonstration in the exam.
Thank you, madam. And madam has always been in the front runner of our academic activities. She has been always part of that. Thank you. Now, coming to this is all about the anterior group of sinuses. What we have done so far, those who have joined late, we did first endoscopic anatomy, then this middle meatal enterostomy after uncinectomy, then we went up with a 70-degree to do the frontal sinus work and the anterior ethmoidal skull base work. You can see the anterior ethmoidal artery there with 0 degree now. We'll see the anatomy, we'll see the implications. Why surgeons are so terrified this vessel? What is the implication of injuring this vessel? Though we discussed during our complication talk as well. But again, this is the time in cadaver to discuss certain issues. Now, to finish off this sinus surgery on this side, what is left behind? What is left behind? The thing which is left behind is the posterior ethmoidal work, sinus work, and the sphenoid sinus work. Now the issue is 12:30. बताना मेरे को.
7 minutes left. 7 minutes left.
एक बार में नहीं सुनता क्या? 12:30 हो जो बताना यार. It's useless.
7 minutes left. No problem.
Yeah.
So still 5-6 minutes left for 12:30.
So what are we left with on the sinus surgery on this side? The post-ethmoidectomy and sphenoidotomy. I can go on through this ground lamella. This is ground lamella. See this? This is ground lamella. If I go behind this, the post-ethmoids are supposed to be there. And behind that are supposed to be sphenoid sinus. But it's not always like that. If I go behind like this to the post-ethmoid, keep doing post-ethmoidectomy, I may accidentally enter into the sphenoid sinus if I am not very, very oriented. And in that situation, I may damage the important neurovascular structure in the posterolateral wall. So, my fear is, during this posterior work behind the ground lamella, I need to develop certain landmarks to prevent the possibility of complications. Okay? So the number one landmark we utilize in our practice, this is purely for the junior colleagues to bring something into the practice by default. The first landmark is the maxillary line, the roof of maxilla or the floor of the orbit. This we call it as a life-saving line, life-saving landmark. See, draw a line parallel to the floor of the orbit, medially. This is the first part of the turbinate, this is the second part of the turbinate. In the second part of the turbinate, close to the first part, this is the point of entry into the ground lamella.
Yeah,
This is to answer where to enter into the ground lamella safely. I'll tell you the reason. See this? My
Yes.
point of entry into the ground lamella, and that is so clear. And as I enter, I stay more and more medially. I don't intend to do this post-sigmoidectomy here at this point of time for the reason I need to have certain landmark to define that I don't go accidentally into the sphenoid and damage everything behind. So what I did this opening in the medial part of the ground lamella here. At what level? At the level of the floor of the orbit. And this is, believe me, you go to that landmark publication from Richard Harvey, is another genius from Australia. That man has, has published a book on sinus surgery, which I believe is one of the best so far, the concepts. He has been to Jaipur to our workshop earlier, and Gaurav Medikari, our dear friend, he invited him in Bangalore a few years back. He's an amazing sinus surgeon in Australia, near Sydney. And he revolutionized. He had this landmark publication of emphasizing the importance of the floor of the orbit. As long as you stick to it, you never transgress the skull base. Such an important observation. I tell you reason why he's saying so. So, I went medially through this opening into this medial part of this region. Can you see this? Now let me go more medially. I don't intend to do any sinus surgery or the post-sigmoidectomy at this point unless I find some landmark. See this. For you, I am broadening this approach to show you. Can you see this superior turbinate behind? See this opening. I enlarged so that you can see it better. This is your superior turbinate behind. Before doing this post-sigmoidectomy, I need to develop a landmark of the sphenoid sinus ostium, which you can see here. Why so? Now keeping this mind, in this mind, this sphenoid sinus ostium as a posterior limit of post-sigmoidectomy, I would never enter into the sphenoid beyond the limit of the sphenoid ostium to damage anything. In any given situation of the anomalous carotid artery or optic nerve or whatsoever in sphenoid sinus, they would never come anterior to the sphenoid ostium. So, as long as you stay anterior to the sphenoid ostium, you never damage anything. So, take the advantage of this line, number one, to enter here safely. The another advantage of this line is now, this sphenoid ostium is so favorable, you could see it early. Sometimes you're not able to see it. What we do then, what I'm doing is, I am removing the lower 1/3 of the superior turbinate. This you can do safely without any complication. And what you can do here for the junior colleagues at this point of time, take this line into consideration again. Take this line into consideration here again. When you look for the sphenoid ostium, never go above this line too much. See, this is the level of the orbital roof, orbital floor. Most of the time, this ostium is in the line of this floor. So the bottom line is to stay on the safer side, never to go above it, number one. And go close flush to the septum, not to go flush to the turbinate. Again, you may be pushed into any cell if you go flush to the turbinate. Go flush to the septum, that will always take you in the sphenoid sinus, number one. Why not to go above this line? Because this ostium is never at the level of the floor of the sphenoid sinus. This is high up. This is close to the roof many a times. So if I don't take into consideration this line, and if I am not able to see the sphenoid ostium and look for the sphenoid ostium somewhere above, I may breach the skull base. And that is a disaster. So, this is such a great landmark, this life-saving line. At this point of line, you enter into the this ground lamella, and taking this line into consideration again along the septum, you look for the sphenoid. Sphenoid in any given situation, whether it is a onody or whatever, this entry into the sphenoid close to the septum is always safe. Now, having seen this sphenoid sinus, I will carry out my post-ethmoidectomy. See this? Again, I reiterate the same words I still remember from Dr. Ashish Bhumkar, 2006. This is again like a box. This post-ethmoid is again like a box. See this? The lateral limit is lamina. See here? The medial limit is superior turbinate. And my posterior limit here for the post-ethmoidectomy would be the sphenoid sinus. So now, as long as I stay anterior to the sphenoid, I have no issues, no fear in dissecting the post-ethmoids at all.
Can you show us
No
the
fear.
frontoethmoidal crest, where exactly it is?
Pardon?
Frontoethmoidal crest in this specimen.
Frontoethmoid. What is this terminology, boss? Can you elaborate?
Yeah, Dr. Udbhav is asking, please ask her to show frontoethmoidal crest.
Okay, let's discuss that. So what I am doing that is a post-ethmoidectomy. Now see the clinical relevance of what I was saying. First of all, I welcome Professor Muaz Tarabichi, who has joined us
12,
as our
30
guest of honor today.
Yeah.
And this is a very important emotional moment for us to remember someone who is father figure to us, the father of endoscopic sinus surgery, Professor Stemberger, whom for which we'll take a 5-10 minutes break like I told you earlier to remember that great man. So after this, so now why I was saying this is a life-saving movement for all sinus surgeons. Believe me, take this sphenoid sinus as a landmark. See what can happen. What can happen? This I was doing this post-ethmoidectomy. See this? If I don't consider this as my posterior limit, if while doing post-ethmoidectomy I am carried away posteriorly, see this? What is there? This is optic nerve.
Yeah.
This is optic nerve. See the post-ethmoidal cell taking directly to the optic nerve. And without knowing the sphenoid ostium and my posterior limit, if I go behind and look for my sphenoid sinus behind, it would be a disaster. I will end up making patient blind. That would be a disaster. And what simply can avoid this is, at this point of time, hello, what is there on the screen?
We can see your screen. But
See now, what can simply prevent this is, before doing a post-ethmoidectomy, go medially and find this sphenoid sinus ostium. And taking as a posterior limit, now you carry out your post-ethmoidal work, not going behind this. And see, you can simply prevent this onody situation. Here, this is onody. And what you see here, the optic nerve, not running through the sphenoid sinus. See this? The optic nerve running through this post-ethmoidal cell known as onody cell. This was described by onody. And this I have seen several times. This is like we discussed last time when Professor Sethi was here. This is more prevalent among the Chinese population. They have almost every other patient have onody. Not in India. India up to 20 to 30% situation we have seen. But see, this approach of going and seeing the sphenoid ostium first and then staying anterior to it can certainly avoid this mishap. Now, having seen this, now what I am doing is, I am enlarging this sphenoid sinus ostium under vision, staying close to the anterior wall, not doing any sharp instrumentation inside, just enlarging the anterior wall to see the interior of the sphenoid. And this is again a very, very important dictum by Professor Stemberger. Always I have attended his courses, not to use any sharp instrument inside the sphenoid sinus. And reason is, you can see what is there, the tiger behind the internal carotid artery. See the carotid artery, the optic nerve, the sphenoid sinus. The bottom line is, while doing a post-ethmoidectomy work, you have to stay extra careful. Go to the medial side, look at the sphenoid sinus, make it as a posterior limit of posterior thyroidectomy, define that, and then go for a sphenoidotomy and widening the sphenoid to carry out a safe sinus surgery. And this is what important, because remember, the same words from Mosher 100 years back, the easiest way to kill a person is posterior thyroidectomy, and if you do like that, you can easily injure the internal carotid artery, which is there. There are a lot of reports published where people have done it. So this is our submission to use this approach. Before doing a posterior thyroidectomy, go medially and see the sphenoid sinus, making it your posterior limit, then do posterior thyroidectomy, and then go ahead with the sphenoid widening to prevent injury. So now is the time to take a 10 minutes break for the great man. Believe me, it will be by watch 10 minutes. We'll get back to the